So about 7:20, somebody stop me so we can do practice time, okay? But 7:20, and then I'll talk for 5 more minutes after 7:20, so it's usually about 7:25. I have to finish my train of thought. And so then we'll practice for that half hour, okay? All right. So heart sounds, very important. S1, closure of your AV valves, okay? So when you hear the S1, it's your AV valves closing, okay? Your AV valves close, and then you have ventricular systole. Ventricular systole, the semilunar valves open. Closure of the semilunar valves is S2, okay? So S1, AV valve closing, S2, semilunar valve closing. Okay, that's exactly what it is. The opening doesn't make a sound. It's the closure of the valves that makes the sound. Okay? S3 is an abnormal heart sound except pregnancy and young athletic people. Okay? It indicates early diastolic rapid ventricular filling. Okay? That's S3. Pregnant people is a normal finding. Young athletic people is usually a normal finding. S4 indicates a stiff ventricular wall. S4, stiff ventricular wall. People with S4 is almost always pathological. It's usually, there's 1 or 2 authors that says it's not, but it's usually almost pathological. And S4 indicates a stiff ventricular wall. What will give you a stiff ventricular wall? Things like hypertension, chronic hypertension. Chronic hypertension increases systemic vascular resistance. The increase in systemic vascular resistance give you a big ventricular wall. I go to the gym. I like biceps. I like to look like good biceps. So I lift weights repetitively. When I lift weights repetitively, I get hypertrophy of my bicep. The same thing happens if the heart is pumping against the systemic vascular resistance. I get hypertrophy of the myocardial muscle. Okay? You can have an eccentric or concentric hypertrophy. Hypertension gives you this eccentric hypertrophy where the myocardium gets really thick. And so they usually have what we call a diastolic heart failure, where the ventricle becomes really small. Okay? Because the myocardium, the muscle gets thick, and then the chamber gets smaller because the myocardium is so thick. So they still have decreased cardiac output because now, instead of having a whole lot of fluid in the ventricle at the end of preload, they don't, because the ventricle is getting so small from the hypertrophy that they have a small ventricular filling. Okay? So when you think about stiff ventricular wall, you want to talk about wall that's not moving. And what can give you a wall that doesn't move? An MI. So if I knock out the anterior wall, if I infarct the anterior wall, that part of my cardiac chamber is no longer contributing to contractility. If that part is not contributing, that part is stiff. Okay? When you hear an S4 sound, S4, you will see patients who have I lost my train of thought that quick. I'm gonna get back to it. I was gonna say something important, but I don't remember what it was. Can I tell you? I'm so gonna get her. Wow.
We have pretty good hearing.
I don't understand. I I got mama ears, girl. So S3, rapid ventricular filling, increased fluid volume states. So heart failure will give you an S3, okay? S4.
Is a gallop an S3 or an S4?
Gallop, atrial gallop is an S4, okay? You have a stiff ventricular wall, okay? If you're pumping, if the atria is trying to get that kick out with this stiff ventricular wall, you get that S4. That's that atrial gallop that you hear.
It sounds like horses.
Yes, like they call it S3, Kentucky, 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 Kentucky. S4, Tennessee, 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 Tennessee. That's your S4. That's your atrial gallop. So your atrial gallop is an S4, stiff ventricular wall. Okay? So the atria tries to give that last kick, and it can't because that ventricle is so stiff. So you hear that gallop. Okay? Does that sound good? That's S4. Kentucky. I know I'm not the best drummer, but come on. Kentucky, 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 Tennessee, Tennessee, Tennessee. Okay? S4, atrial gallop, Tennessee. S3, increased fluid volume states. Okay? So, MI, S4. Hypertension, 4. Heart failure, pregnancy,
S3. No,
S3. Okay? Young athletic, S3. Okay? S4, atrial gallop. If you hear anything about atrial gallop, you know that the atria is trying to get that atrial kick against the stiff ventricular wall. That's your Tennessee. Tennessee. That's your S4. Your S3 is whoosh, too much fluid, increased fluid volume states. Okay? Kentucky, Kentucky. All right? Make sense? Okay. Split. Okay? S1 is closure of the mitral valve. You can have a split between M1 and M2. It's really detectable. Now, S2, you can have a physiologic versus a paradoxical pathological split. During inspiration, if you hear a split between the S2 sound, which is a separate sound you hear from closure of the aortic valve and the pulmonic valve, it's usually during inspiration. Because if I take a deep breath, my lungs expand, my chest cavity opens up, and blood rushes into the right atrium, into the right ventricle, okay? If I take a deep breath during inspiration, the pulmonic valve gets a rush of blood to it. So it actually closes a little bit later than the aortic valve. So that's where you hear that physiological split during inspiration. Once the chest cavity opens, blood rushes in, you hear a physiological. Anything that's physiological happens normally. So a physiological split occurs in S2 during inspiration. Okay, opening up the chest cavity, more blood flow into the right atrium, into the right ventricle, through the pulmonic valve. There's a delay because there's an increased amount of blood trying to go through the pulmonic valve. So A2, the aortic valve closes, and then that little bit of blood that stops P2 from happening is because of inspiration. Okay? So during inspiration, if you hear a split between A2 and P2, that's physiological. Nobody usually hears these except cardiologists who like listen 1,000 times, and these are the nerdy cardiologists, because the regular ones.
What is that sound?
It's just, in S2, you will hear like, kind of like a 2 beats in S2. So you have lub dub, is lub dub dub. You'll hear like lub, like a dub dub.
So how do you know
Dub.
between that and
Don't know.
a cardiologist?
Don't know.
So I don't need to know that.
You don't need to know that. All you need to know,
Nerdy cardiologist.
nerdy cardiology. Okay? Usually, it is picked up if it's really loud. Okay? And it's a physiological S2. A paradoxical split or a non-physiological, which will make it a pathological split, means that it's associated with a condition that is not normal or some kind of pathological process, which means it's a disease process, is a split on expiration. Okay? Because you don't have that influx of blood that delays P2. So on inspiration, if you hear a split on inspiration, it's usually associated with some kind of disease process. A left bundle branch block, okay, will give you a paradoxical split on S2. Okay? Does that make sense?
Is that only every once in a while associated? Because my dad's got a left bundle and
I don't think everybody has it, but can be associated. Try listening, maybe. Okay, so your valves, we talked about the AV valves and your semilunar valves and when they're open and when they're closed and what opens when and what closes when. Okay? So we're gonna talk now, we talked about this already. Effects of heart rate on cardiac output. I love this slide. It puts things into perspective for nurses. Okay? If your cardiac cycle takes 1 second, your heart rate is 60 beats per minute, your systole is 30% of your cardiac output, and your diastole is 70%. That's 1/3 and 2/3, correct? Right? If your heart rate, if your cardiac cycle decreases to 0.66 seconds, taking away 0.44 seconds, your heart rate is 90. That means your systolic phase is 45%, and your diastolic phase is 55%. Now, if you decrease the cardiac cycle by half, increasing the heart rate twice the amount, your systole phase is 60%, and your diastolic phase is 40%. Which gives you what? Lag in filling time. And if you don't fill, do your coronaries perfuse? No. Myocardial ischemia. So that puts it into nice perspective. There's a question I always put on the quiz of the test, and I can't remember the question right now.
Thanks for mentioning.
I know. Just flag it and remember it. That's all I'm saying. Like, dude, I'm giving you a clue. There's a question on this somewhere.
Next slide.
Just showing it out there.
The next
Just
slide.
showing it out there.
Oh.
All right, the things that affect your heart rate. Your autonomic nervous system, autonomic innervation, epinephrine, norepinephrine, cortisol, all these things increases heart rate. Fitness level can decrease heart rate. Someone who's very physically fit and the myocardium is nice and strong, does not beat as hard, but doesn't beat as fast, but beats, has good contractile force and can actually expel blood. Younger people usually have a better heart rate than older people. Okay? Heart size, whether it's too big, too small, usually it's the size of a fist, that's the size. Gender, females usually have higher heart rates than males. The ability to contract, duration of contraction, how fast it contracts, preload and diastolic volume, afterload, resistance, all impact your cardiac output. Okay? We talked about these. I don't know why I have it twice. Well, we talked about these. Anybody have any questions on S3 or S4? No, right? Left ventricular hypertrophy. Where do we get left ventricular hypertrophy? Hypertension. Restrictive cardiomyopathy, that usually means that the heart is not being able to beat as well because you have some kind of disease that kind of restricts it. Usually things like scleroderma can give you restrictive cardiomyopathy. Okay. Hypertension. S1, we talked about it. S2, we talked about this pathological split versus physiological split, and we talked about all these. Heart sounds, we talked about the extra heart sounds for open and stop. Systolic click, usually you can hear a mid-systolic click, and you will hear that more in mitral valve prolapse, right, than anything else. We're gonna talk about murmurs, and that's what all this stuff under here is. And when we talk about murmurs, we'll describe it a little bit more. Okay. Stenosis. Stenosis happens when a valve that is supposed to be open is not opening all the way. Okay? Regurgitation occurs when a valve that is supposed to be closed doesn't close all the way. Okay? So I use the analogy of the door. If the door, I'm trying to get out, and it's supposed to be open, and it has a tight opening, and I'm trying to get out, I'm gonna hit up against the door to try to get out. That's the sound you're hearing from the murmur when you have a stenotic murmur. Murmur is like rumbling, it's turbulence, okay? It's the blood hitting up against the valve. Because the valve is so narrow, it can't let blood out. Regurgitation, I open this door, and I wanna close it, but when I close it, it just swings back open, okay? That's a regurgitant valve. It doesn't close all the way. So a stenotic valve doesn't open all the way, and a regurgitant valve doesn't close all the way. So when you're listening to murmurs, you need to know where the murmur is, when is it occurring during systole or diastole, and then you can determine what type of murmur it is. Okay? So I have Mr. Smith who comes in, and Mr. Smith, on examination, has a murmur. It is a murmur that is heard on systole, and it's auscultated best at second intercostal space right of the sternal border. What valve is second intercostal space right of the sternal border? The aortic valve. What is the aortic valve doing during systole? It's open, right? So if I'm hearing a murmur during systole from the aortic valve, I have a stenotic aortic stenosis. Does that make sense? Mr. Jim is a 50-year-old man that comes in and he has a murmur. His murmur is heard at the fifth intercostal space, mid-clavicular line, and the murmur is heard during diastole. So, fifth intercostal space, mid-clavicular line, I need you to locate the valve first.
That's the mitral.
The mitral. What is the mitral valve doing during diastole? It is open.
Open, yeah.
So if the mitral valve is open during diastole, it is a stenotic or regurgitant murmur. Stenotic. Because it's not opening all the way. Does that make sense? Jim is a 75-year-old male that comes in. He has JVD, hepatosplenomegaly,
That's
right-sided.
here.
He has a murmur that's heard fifth intercostal space left of the sternal border, and you hear it more on systole.
It's supposed to be closed.
So, if I have fifth intercostal space, left sternal border, what valve is there?
Tricuspid.
Okay? And what is a tricuspid valve doing during systole?
Close.
It's supposed to be closed. So it's a tricuspid.
Still good.
Okay? Does that make sense? So, to sum it up, I need you to know where the murmur is, what is that valve doing at that time during systole or diastole. You're always going to have a question telling you it's systole or diastole. Okay? So you have to know what that valve is doing during systole, what that valve is doing during diastole, and where is that valve located. Okay? Make sense?
Yes, ma'am.
So how to describe a murmur? They're going to tell you. And your question is going to say, this is and they have them here, and I'm going to go through them, but I don't want you to pay attention to the noise. It's a whole lot of noise in the question. It's going to say, Mr. Smith is a 50-year-old man that comes in with a crescendo, decrescendo murmur that's heard in the fifth intercostal space, and it radiates up to the arm and all that crap. And it's heard best during systole or diastole. I want you to block out the noise. I need you to say, where is the murmur? When is it heard? And then start making your diagnosis based on that. Do not get caught up in the noise. Because you see it, you go, crescendo, decrescendo, oh my God. I just need you to pay attention. Where's the murmur? When is it heard? What's happening in stenosis? What's happening in regurgitation? Pay attention to the details, not the noise. The noise is important, you'll learn in a few, but I need you to pay attention to the details. Don't let the noise distract you. It's a lot of distracting noise. Okay? So, how to describe a murmur? Timing. Is it systolic, diastolic, early, late, middle? Shape. Is it a holosystolic, holodiastolic, or is it a crescendo murmur? Means it gets loud as it goes. Or is it a crescendo, decrescendo murmur? It gets loud and then it drops. Okay? You have to know all that. Does it radiate? Okay? When does it radiate? If I have a murmur that radiates to the carotids, what does that tell you? It's aortic. Because guess what? The aorta feeds the carotids. So if it's going to the carotids, make sense? Right? Yes. Now, intensity. This is what Kim was asking about when she was like, it's 1/6 or 2/6 or 3/6. All this stuff. Intensity, 1, it's very audible. It's like you have to listen with your stethoscope. Really hard. The room has to be completely silent for you to hear it. Okay? Or you have to have a really good hearing. 2, the stethoscope, you can hear it. 3, it's audible. Audible means I don't need a stethoscope. I can just hear it. Yes. We have those. Now, this is where it comes. You have audible without a thrill and audible with a thrill. Your test questions are usually gonna ask you audible, audible without a thrill, audible with a thrill. Audible without a thrill is a 3 out of 6. Audible with a thrill, remember a murmur is a bruit. A bruit is what you auscultate. A thrill is what you feel. Okay? Both indicate turbulence. So if you're feeling it, it's a thrill. If you're hearing it, it's a bruit. A murmur with a thrill is 4. A murmur that's audible without a thrill is 3. So audible without a thrill, 3. Audible with a thrill is 4. Make sense?
Is it 4 because it's worse?
Yes, ma'am.
The higher,
higher
the greater
number,
the worse.
The murmurs. Okay?
Dumb question.
A 6 is usually audible without a stethoscope, touching or palpating. Or palpable. That I've never heard. I remember when I went to this Barkley review, he said that's like some Jarvis heart, some kind of imitation heart, because you never hear that. Okay? 5 is audible with the rim of the stethoscope and palpable.
Which one requires surgery?
Sorry?
Out of the 3?
It depends on what's going on with the patient.
I had a patient severe aortic stenosis and I could hear
Start getting concerned or something
the
like that.
stethoscope very, very bluish with a wishing sound.
Oh, yeah. So how is she doing?
Not good, it was a continuous process.
Oh, makes sense. I mean, anything that's not causing symptoms don't need to be replaced. But if it's causing symptoms, that's when you have to look at it.
What's the difference between 4 and 6?
4 and 6, audible without stethoscope, touching or palpable.
But like,
It's-
when you say palpable, you mean palpable thrill? Or
Palpable thrill, you can hear it. You can hear it standing over here. It is that loud. You don't need anything. Okay? Audible and palpable thrill is usually this one with 6, no stethoscope. You just see it moving. That's usually what they're talking about when you talk about 6. 6 is just like, yeah, you're dead, pretty much. Or you have like some kind of heart that's man-made or something. Okay? So usually your questions will trip you up. They're gonna tell you it's audible and no thrill. Or they're gonna tell you it's audible with a palpable thrill. Your questions are usually after long auscultation, it's a 1. We usually ask you audible or audible with a thrill. Those are usually our questions, because we want to know if you're paying attention. Because those are the 2 you can decipher. Okay? So it's usually 3 or 4 or 1. 2 is too hard to describe. So you're not going to get a question on 2. You're not going to get a question on 5 or 6. If you get a question, it's going to be 2, 3, 1, 3, or 4. Note to self. We'll learn 1 to, 1, 3, 4. Okay? Pay attention to those. Okay? So valvular stenosis, louder in advanced disease, except when heart failure is due to decreased pressure. Okay? Usually then it becomes softer. Okay? Valvular insufficiency would cause a murmur. Of course, we talked about regurgitation. If the valvula is insufficient, it doesn't close. It's like a regurgitant murmur. Okay? Congenital anomaly or abnormality, okay, will give you a murmur. The other things that will give you a murmur: increased blood flow. Someone who is in a hypermetabolic state, you can actually hear a murmur. Hypermetabolic state is usually a thyroid disease. Okay? Decreased blood viscosity during anemia. Those things will give you the sound murmur. Okay. Congenital heart murmurs, mitral stenosis. Again, is the crescendo, low pitch rumbling, diastolic. Again, if it's stenosis, we know that the mitral valve is doing what during diastole? It's supposed to be open. So of course it's a stenotic murmur. How do you hear a mitral stenosis? You're gonna have them lay on the left side and you're gonna listen to the left, in the left lateral decubitus position. Okay. Mitral regurg, loudest at the apex, usually radiates to the axilla. It's mitral regurg. If it goes to the carotid, it's aortic stenosis. If it goes to the axilla, it's mitral regurg. Now, aortic stenosis and mitral regurg are both systolic murmurs. Okay? So, you can mix them up. If it's a murmur during systole, remember, the mitral valve is closed during systole, so it could be a mitral regurg, or it can be an aortic stenosis because the aortic valve is open during systole. So if they give you it radiates to the axilla, it's a mitral regurg. If it radiates to the carotids, it's an aortic stenosis. Those are just extra clues, but basically where it is and when it's happening is going to give you the most clues. Okay? So if they tell you it's a systolic murmur that radiates to the axilla, you know it's not aortic stenosis, it's mitral regurg. They're both systolic murmurs. Okay? If they give you a murmur that radiates to the carotid, it's aortic stenosis. Make sense? All right? Mitral regurg is holosystolic, it's harsh. Aortic stenosis, it's a medium pitch, and it's a crescendo, decrescendo. Means it starts low, goes high, and then goes low again. So it's a triangular shape. Okay, type of murmur. And the aortic regurg, it's a diastolic murmur, and again, second, fourth intercostal space. It can radiate to the apex, but if it starts in second to third intercostal space that radiates to the apex, you know it's not coming from the mitral valve, it's coming from the aortic valve. Make sense? All right. Aortic sclerosis, loud murmur, usually it's a cooing type murmur. Aortic stenosis, late systole. This murmur sounds a lot like the murmur of, I don't have it here. Aortic stenosis is a crescendo, decrescendo systolic murmur. Okay? Patients with hypertrophic cardiomyopathy also have a systolic crescendo, decrescendo murmur that we're going to talk about in a little bit. I know I have it in here somewhere, but mitral, what do you call it? Myocardial hypertrophy, cardiomyopathy. Oh. Hypertrophic cardiomyopathy. Can we remember the word? My God. Hypertrophic cardiomyopathy is a problem where they usually have a very large septum. Okay? And usually they discover them in young people, young athletes. They start running and all of a sudden they pass out because they can't get any oxygen to the brain. Usually that's a simple episode. Can't get oxygen to the brain's not very forgiving. It goes, you pass out. But they have a murmur, and their murmur sounds a lot like the murmur of aortic stenosis. Now, you're going to have to differentiate between the two. The aortic stenosis and the hypertrophic cardiomyopathy. They're both a crescendo, decrescendo murmur that's heard best in systole. Okay? But certain things that you're going to do with the patient is going to tell you whether it's a hypertrophic cardiomyopathy or a aortic stenosis. Hold on. Let me go down because I want to draw it on the board. It actually gives me a little bit more. Yeah, there's a board back there. This guy. this is what it usually looks like. Hypertrophic cardiomyopathy. This is what usually gives you this problem. It's this large septum, okay, that you usually have in hypertrophic cardiomyopathy. And so you get the same crescendo, decrescendo murmur that's heard in systole, okay? But usually what you can do is have the patient do different activities. So squatting, when you squat, I do this. When I do this, what do? I am actually increasing blood flow through the heart when I squat. How am I increasing blood flow through the heart? Because I'm actually clamping off the vessels. And actually, if I'm clamping off the vessels, I'm getting more blood flow going up. Okay? So if I have more blood flow going up, okay, if I squat or I have hand grip, I have more blood flow going up, I have more blood flow pouring into the heart, it's actually going to open the valves a little bit more, so you actually hear the murmur of hypertrophic cardiomyopathy less.
It doesn't make a difference if it was aortic stenosis, right?
Aortic stenosis. What will make aortic stenosis murmur less? Aortic stenosis, you hear it more when blood is coming out, right? Right? So if I Valsalva, I'm actually increasing intrathoracic pressure. Am I getting a lot of blood flow out?
No, you're pushing it
No.
back. Kind of like,
Yes, because when I do this, I bear down. That's usually when people pass out. I mean, I do that too long. I know, I'm about to.
The 80s right outside to the right.
So if I bear down like that, I'm increasing my intrathoracic pressure. If I'm increasing my intrathoracic pressure, I'm blocking the outlet of blood through the aortic valve. So with Valsalva, the aortic stenosis murmur is less. With squatting, the aortic stenosis murmur is more. Because with squatting, I have more blood going into the heart. Of course, more blood is going to come through the aorta. With hypertrophic cardiomyopathy, if I squat, the murmur is less intense. And if I Valsalva, the murmur is more intense. Because now I'm squeezing the heart, and that big septum is hitting up against the wall of the heart, and that's giving me more blood flow. Does that make sense? The pathology makes sense?
getting there.
So we're gonna talk about it. They're both crescendo, decrescendo murmurs. Okay? Right? They're both. You'll hear it. So I don't have to draw it. I had a picture. My drawing sucks. Anybody can tell you. All my students from Patho, they laughed. Every time I drew something on the board, they made fun of it. Don't draw out. Mitral valve prolapse. What I want you to remember, anytime you hear mid-systolic click, it is a mitral valve prolapse. The only murmur that has a mid-systolic click is a high-pitched mid-systolic click and runs into end of systole. Okay? That is mitral valve prolapse. Those are the words I need you to remember. Mid-systolic click, mitral valve prolapse. Connect them in your brain. So the question asked you, and they tell you about this patient that comes in, and the patient has this murmur that's going all the way to the apex, and you hear it best with systole, and it has a high intent mid-systolic click. Mitral valve prolapse. All right? Alright, guys? And then, you actually, when you're studying, you actually hear me and you see me moving. Remember everything. Unless you make fun of me like the girl in blue. Alright. So mid-systolic late systole, crescendo murmur, mitral valve prolapse. Okay. Ventricular septal defect, atrial septal defect. If you have a ventricular septal defect, what do you hear? What do you have?
A murmur.
Oh yes, of course.
The pantystaltic is large.
Shunting. And where does blood go from? The ventricle. It's usually shunt from an area of higher pressure to an area of lower pressure. So it goes from the left ventricle to the right ventricle. Okay? Remember, you have the high pressure in the left ventricle, the low pressure in the right ventricle. Okay? Atrial septal defect. Oxygenated blood shunted from the left atrium to the right atrium. Okay? These are the only conditions that you're going to have blood shunting. If it's going from ventricle to ventricle, don't call it an atrial septal defect, please. Because it's going from ventricle to ventricle. This is in here, and I tell students every time, do not memorize this crap, because on your test, when you have a whole bunch of questions, you're going to start mixing crap up. Because then you're going to go, is it Miss Art or Mr. Art? Is it Miss Ass or Mr. Ass? What is it? And you won't remember crap. I want you to know, when is a systolic murmur? I want you to know where it is, what it's about doing during systole, what it's about doing during diastole, and there you go, figure it out. Do not do this, Miss Art or Mr. Ass. I'm gonna say it, and guess what? Test day is gonna come, and they're gonna pull out the paper, and they're gonna write Miss Art, or something to that effect. I don't want you to go by this. I want you to go by which valve is open when, which valve is closed when, what they're doing where, and where it's located. That will help you the most. Learn it, and it will help you. Okay? Yes. S3 and S4 diastolic murmurs, both heard normal and pathologic, age dependent. We talked about S3 being pregnancy, younger people, S4 stiff ventricular wall, S4 is almost always pathologic. We talked about that. No, not everybody has it, but it can be present. It will be a normal variant, yes. Okay? Unless she's in some kind of heart failure or something. And if she's not having any other signs of heart failure, it's likely not pathologic. Okay? Timing of murmurs, again, I don't care about this. I don't care if it's mid-systolic, late systolic, early systolic, blah, 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 I don't care. It's just a lot of noise in the question. What I want you to realize is when it occurs, what phase of the cardiac cycle it occurs in, and where it's heard best, okay? So, aortic stenosis is early systole. Mitral regurg is a polysystolic murmur, heard best early and late systole. Aortic regurg is heard mid to late diastole. Mitral stenosis is all over the place. Patent ductus arteriosus It is a whole lot of murmur. So the timing again, early, late, pansystolic, usually from the beginning of S1 to S2, holosystolic. Pansystolic and holosystolic, I would never ask you that question because I think it's just really ridiculous that they have a pan and a holosystolic, and you never see that in the diagnostic exam anyways. But pansystolic from S1 to S2, holosystolic from S1, from the end of S1 to the beginning of S2. That's the distinction. Okay? Holodiastolic versus pre-systolic, those are there. Shape of the murmurs, crescendo, we talked about, it rises, decrescendo, it drops, crescendo, decrescendo, it rises and then drops. Uniform is just all throughout. Okay? This is just what that other slide says. Okay? This talks about the murmurs of systole and the murmurs of diastole. We talked about them. Hypertrophic cardiomyopathy is one that actually sounds like aortic stenosis. Pay attention to those two, because when you get those two, I'm gonna say something like, and it increases with Valsalva. It increases with Valsalva. I almost fainted. Hypertrophic cardiomyopathy. It decreases with Valsalva. Stenosis. It increases with hand grip exercises or squatting.
Stenosis?
Stenosis.
Stenosis.
It decreases with hand grip exercises. Hypertrophic cardiomyopathy. Okay? Make sense? You say yes now. Systolic, mid-systolic, that tells you when it occurs. Grading of murmurs, we talked about this. Diastolic murmurs are usually 1 out of 4. Systolic murmurs are usually 1 out of 6. Usually, you get more systolic than diastolic murmurs. This is a chart that actually maps out where you hear the murmurs best. But again, listen to it about this. Some radiate to other places, some heard best in other places. Like the murmur of aortic regurg, you hear it best at Erb's point. Pulmonary stenosis, you hear it best at like Erb's point, depending on what's going on. S3, ventricular gallop versus your atrial gallop. Remember your S3, increased fluid volume states, occurs early diastole, S4 late diastole, filling, maybe normal at times, F4 always pathologic. S3 requires very compliant left ventricle, and S4 requires a non-compliant ventricle. S3 can be a sign of systolic heart failure, and S4 can be a sign of diastolic congestive heart failure. You can hear some murmurs on this if it still works. I didn't check it, I'm so sorry. But sometimes we have a link in there, and then you go and it gets worse. I mean, it disappears. So look at, check and see if the link works. Again, hypertrophic cardiomyopathy, crescendo, decrescendo, hand grip exercises, which is increased afterload. Hand grip exercises or squats increases your afterload. That will make the murmur of hypertrophic cardiomyopathy less intense. Valsalva, or, and they say Valsalva release, okay, versus Valsalva. Valsalva release will be your squatting. So it's Valsalva or standing. Valsalva will make the hypertrophic cardiomyopathy more intense, because when you increase interthoracic pressure, that heart is squeezed a little bit, that symptom is going right up against that, valvular wall, and you can hear the murmur much more, okay? I'm sorry.
20.
720. I got you. Hypertrophic cardiomyopathy, usually they have very thick septum, it takes up the wall of the ventricle. Things that usually happens is usually, outflow obstruction. So usually what happens is they're running, they fall, you have fibrosis or scarring of the heart, usually sudden, death syndrome. Sudden cardiac death syndrome is usually associated with it. Usually they get, this due to, what do you call it, arrhythmias. The number one arrhythmia associated with hypertrophic cardiomyopathy is ventricular fibrillation. So the treatment of choice for these people is usually an EICD. So they usually get an EICD. I don't see people writing. Ask questions. Ventricular fibrillation is the arrhythmia associated with hypertrophic cardiomyopathy. And that's why they get an EICD placed. See? I can see you guys don't know what I'm talking about, a test question. Repeat it a couple of times before people will do it. Okay. Again, HOCA, Valsalva, increase. AS, Valsalva, decrease. Squatting, Valsalva, decrease in HOCA, increase in aortic stenosis. And you understand the mechanism of why that happens, correct? Alright. Okay, we're out of murmurs. How many slides do I have left? 40.
It's supposed to be 104.
104.
71.
I have 66 left.
38.
Oh, yeah, I talked a lot.
38 left.
A lot of this we talked about, so we'll go through that class next week. Before we go into it. All right, we have cardiac next week again, so
Hey.
still have time. All right, so pick a partner, any partner,